doctors. I am DP Gupta, Division Head from the Gastroenterology from the MSN labs. The creative capacity of human mind has always been the source of inspiration. At MSN, we believe every life matters and everyone deserves the quality medicines. Apart from the affordability and accessibility, we want to be the first to touch the human life. We are MSN, serving the patients better today and tomorrow. MSN is truly globally Hyderabad-based pharma company, which has presence in the 65 countries and manufacturing facilities in India and USA. As per the data, India has an estimated 1.5 million patients affected with the IBD, putting the country second only to the USA with 1.6 million patients. A large number of the patients are not responding to the conventional therapy in the management of the IBD. Today, we welcome all delegates and eminent speakers from today's webinar on challenges and newer approach in the management of ulcerative colitis. We have with us Dr. Vishal Bhatia, who is having the experience of more than 25 years in the various diagnostic and therapeutic endoscopic procedures. Since 1993, Dr. Bhatia is associated with the various leading hospitals of Delhi as senior consultant gastroenterologist. He is involved in clinical trials of various newer drugs in patients with the IBD, and he is actively involved in teaching of the DNB students in current hospital and has been thesis guide to the more than 5 students. We also have with us Dr. Rajesh Puri. He is the Senior Director, Medanta Institute of Digestive and Hepatobiliary Sciences, an adept gastroenterologist with more than 20 years of the practice. Dr. Puri is dedicated to the profession with exemplary success in interventional gastroenterology in North India. Dr. Puri has been elected as the Secretary of SGEI and member of the Asian EUS Society. Dr. Puri is involved in various social activities and extensively working towards serving the humanity, especially the poor and sick patients. We also have with us Dr. Pawan Rawal. Dr. Pawan Rawal is Unit Head Gastroenterology in Artemis Hospital, Gurgaon. Dr. Rawal is expert in various diagnostic and therapeutic procedures in gastroenterology, hepatology, and in its application to the patient care. Dr. Rawal is well versed with the management of all kinds of the intestinal, hepatic, pancreatic, biliary, and systemic disease. Dr. Rawal has contributed more than 3 chapters in the gastroenterology books. He has keen interest in research and has attended various national and international conferences, international therapeutic endoscopic workshops, and CMEs. Dr. Rawal has more than 30 plus publications to his credit. We also have with us Dr. Abhishek Kathuria. After completion of his super specialization in gastroenterology, he has done 2 fellowships, one in advanced endoscopy and another in the liver transplantation. Dr. Kathuria has the area of interest of the luminal gastroenterology, endoscopy, and liver disease. Dr. Kathuria is a member of American Society of the Gastrointestinal Endoscopy, American College of Gastroenterology, and Indian National Society of Liver Disease. So we welcome Dr. Vishal Bhatia, Dr. Pawan Rawal, Dr. Rajesh Puri, and Dr. Abhishek Kathuria. I request Dr. Bhatia to take over the session and invite our first eminent speaker. Dr. Bhatia, please.
Good evening, everybody, and welcome to this webinar on challenges and newer approach in management of ulcerative colitis. Our current therapeutic arsenal of ulcerative colitis treatment consists of 5 groups. One is steroids, another is 5-ASAs, then immunosuppressives, then anti-TNF agents, and integrins. But still, with all of this therapeutic armamentarium, around 1/3 of our patients do not respond. They are either primary non-responders or they become a secondary non-responders. So there's always a space for a newer agents to fill up this gap of 25 to 30% of the patient who do not respond. And since 2018, we have got a newer group of agents which are known as the JAK inhibitors, and which have been approved for usage in ulcerative colitis. So today's session is dedicated to the JAK inhibitors, and for this session, the first topic or first session is on role of JAK/STAT pathways in ulcerative colitis pathogenesis, for which I invite Dr. Rajesh Puri to give his talk, so that we know that how these pathways impact the pathogenesis of ulcerative colitis. Dr. Rajesh Puri, please.
So thank you, Dr. Vivek and MSN Laboratories for giving this opportunity. I'm a little bit changing. I'm sorry for that. First of all, I'm thankful to MSN for giving me the opportunity. But Dr. Abhishek Khathuria is my colleague, and he is very much passionate about the inflammatory bowel disease and luminal. He is doing single balloon, double balloon, and the spiral endoscopy. So I thought now today is the world where you have to collaborate together and work. So I would like to request Dr. Khathuria to speak on my behalf, and I hand over to Dr. Khathuria for talking on this. I will be in the meeting throughout, and I will be also happy to answer if any question to me or Dr. Abhishek Khathuria.
Thank you, sir. Good evening, everyone. I would like to thank Dr. Rajesh Puri for giving me this opportunity, and MSN Laboratories for presenting the topic of ulcerative colitis, its pathogenesis, and the role of the JAK-STAT pathway. See, as we all know, that ulcerative colitis is a multifactorial immune disorders of chronic relapsing inflammation of the intestine. It can clinically present as a diarrhea, hematochezia, or abdominal pain. There are certain factors which can cause ulcerative colitis, various genetic factors, environmental factors, and immunological factors. All these triggers, they can normally lead to the inflammation of the gut flora. Now, how do the pathogenesis of ulcerative colitis takes place? See, under normal physiological conditions, the intestinal lumen has got good bacteria, which is the commensal bacteria, as well as certain pathogens, and the mucus layer is intact, and the epithelial barrier and the tight junction is there, and the lamina propria is in the stage of physiological inflammation, and the homeostasis is maintained between all three of them. This homeostasis is disrupted in a susceptible individual by specific environmental factors and genetic factors, which leads to altered microbiota and dysbiosis, leading to leaky gut, resulting in hyperactivation of T helper cells and Th17 cells, chronic inflammation, and ulcerative colitis. Now, as we can further see, there are many environmental factors like smoking, stress, drugs, diet in genetically predisposed individuals, which leads to intestinal dysbiosis and leakage of the epithelial barrier, leading to mucosal immune system inflammation and recirculation of the inflammatory cells. Now, there are multiple inflammatory cytokines which are overexpressed in this process, and we discuss the mechanism in detail in this picture. Now, as we can see in this picture, in the colonic lumen, in the normal cell, we have a mucinous layer, and the mucin is protective. But in a patient with inflammatory bowel disease, we can see there is an defect in the mucosa. So what happens? So there is disruption of the tight junction. We can see that in a normal cell, the tight junction is intact, but in a patient with inflammatory bowel disease, there is disruption of the tight junction, and the mucus film covering the epithelial layer causes increased permeability of the intestinal epithelium, resulting in increased uptake of luminal antigen. Now, what do these antigen lead to? These antigen further lead to activation of dendritic cells and macrophages, and through the toll-like receptors or molecular pattern recognition receptors, these antigens further activate the dendritic cells and change the functional status of the bacteria from tolerogenic to an activated phenotype. Further activation of the NFKB pathway by the macrophages leads to transcription of pro-inflammatory genes, resulting in increased production of pro-inflammatory cytokines, the TNF alpha, IL-22, IL-23, IL-12. We'll be reading about them in our coming slides. Then, after the processing of the antigens, macrophages and dendritic cells present them to the naive CD4 T cells, promoting differentiation into Th2 effector cells, characterized by production of interleukin-4. And natural killer cells are the main source of interleukin-13, which have been associated with disruption of the epithelial barrier. So we can see that in all these processes, there is a profound inflammatory response which takes place. The circulating T cells bearing alpha 4 beta 7 bind to the vascular microvasculature of the endothelial cells through MADCAM1 molecule, whose expression is enhanced in the inflamed dentate site, leading to increased entry of the gut-specific T cells into the lamina propria. And lastly, the upregulation of inflammatory chemokines, the CXCL1, CXCL3, and CXCL8 leads to recruitment of circulating leukocytes, which perpetuate the cycle of inflammation. Now, what is Janus kinase? It is basically an acronym for JAK, which means just another kinase. They are basically a family of tyrosine kinase, which are 4 large peptide members, which is JAK1, JAK2, JAK3, and tyrosine kinase 2. It is named after the Roman god Janus, which is a two-faced god of gates and doorways. As we can see that the Janus molecule has both a catalytic and a pseudokinase domain. It is also related to the pathway of the STAT, which is a signal transcription and activator of transcription, in which we have 7 transcription factors. Now, how does the pathogenesis of JAK-STAT pathway takes place in the inflammatory bowel disease? As we all know that there are many cytokines which are important in the pathogenesis of the IBD via the JAK-STAT pathway. Cytokine signaling, it induces the phosphorylation of the JAK, which phosphorylate STAT proteins. We can see that these are phosphorylated JAK proteins, and this phosphorylate the STAT proteins, and these STAT proteins form the homo or the heterodimers and migrate into the nucleus, where they activate transcription of inflammatory cytokine. Again, I'll be explaining this in the further diagram. We can see this is a normal molecule. The cytokine gets attached into it. The JAK is at the tail end of the cytosol. The STATs are recruited to the phosphorylated cytokine receptor, and the STATs are phosphorylated by JAKs, leading to dimerization. And then they are translocated to the nucleus and activation of target gene transcription. There are various cytokines which are involved in the JAK-STAT pathway. This is a list of all of them. Now, in the ulcerative colitis, as we all know, it's a disease of the lamina propria. The T cells, they produce the Th2 type cytokines, IL-4, IL-5, IL-13. In the Crohn's disease, it is primarily the Th1 type cytokines which are responsible. The IL-4 differentiates naive T cells into the cell signaling via JAK1, JAK3, activating STAT6. IL-5 signals via JAK2, activating STAT3 to 6, which is a key mediator in eosinophil activation and promotes B cell growth. IL-13 signals via JAK1, JAK2, TYK2, leading to activation of STAT6, which promotes fibrosis, induces apoptosis, and degradation of tight junction in the intestinal epithelial cells, leading to ulceration. So we can see that there are many interleukins which are involved, and the combination of JAKs and STAT, they differ. In IBD, there is also increased Th17 cell-associated cytokines, and naive T cells differentiate the Th17 cells. Now the IL-6, IL-21 and IL-23, they all signal via the JAK-STAT pathway. So inhibiting this pathway prevents the signaling of the pathogenic Th17 differentiation. IL-22 is another important interleukin which signals via JAK1 TYK2. Now, what do the JAK inhibitors do exactly? They basically interfere with the number of pro-inflammatory cytokines which are involved in the pathogenesis of IBD. This is the list of various JAK kinase inhibitors. They are basically of two types. They are first generation and second generation. The first generation are specific to the receptors and the second generation are non-specific. But if we see that, as we have seen in the pathogenesis, that there are various JAK molecules and STAT molecules which are involved. So the pan-JAK kinase inhibitors, they are the most useful. And in this regard, we have got a drug called as Tofacitinib. This is a diagram which is showing, this is a diagram which is showing at which level, what are the drugs which are working. We have the biologicals, we have the monoclonal antibodies, and we also have the JAK inhibitors in the form of Tofacitinib. Now, a word about Tofacitinib. It is basically a Janus kinase inhibitor. It binds to the JAK enzyme and downregulates the production of pro-inflammatory cytokines, reducing inflammation. It is the first JAK inhibitor approved by the US FDA and EMA. The most important point is it is used in the induction and maintenance therapy of moderate to severe ulcerative colitis in patients who are failed on conventional therapy. The advantages of this molecule is it has got a faster onset of action, short half-life, so less adverse effects. Usually the starting dose is 10 mg twice a day for 8 weeks. And if after 8 weeks there is endoscopic and clinical remission, we can reduce the dose up to 5 mg. And if there is no improvement, we continue the dose for another 8 weeks. And if there is no response in 16 weeks, then the treatment is discontinued. Certain things which are very essential before starting Tofacitinib are: one must assess for risk factors for venous thromboembolism because it has got a prothrombotic effect. Then we should look for the routine panel in the form of complete blood counts, lipid profile, liver function tests. Testing for hepatitis B and tuberculosis is very important. And when this agent is started, the concomitant immunosuppressive agent should be stopped. Thank you.
Thank you, Dr. Abhishek. It was a very detailed description of the JAK-STAT pathways and their role in the pathogenesis of ulcerative colitis. I think we'll take the questions after both the presentations are over. So I'll invite Dr. Pawan Rawal to give us the second talk, that is about leveraging JAK inhibitors to tame the inflammation in ulcerative colitis. Dr. Pawan, please.
Thank you, sir. Thanks a lot, MSN Lab also. I mean, it's a time for dinner. Actually, we should thank the audience as well. This is a Saturday evening and everybody is attending the webinar. So thanks everyone for coming to this session. I think we'll justify next 15 and 20 minutes of our session so that we have some information about the clinical application of what has been presented by Abhishek. So thank you, Abhishek, for setting the ground. I'll be talking more about the clinical application and the uses and the data which is available for the IBD. Since the Tofa is actually approved for UC as of now. So we'll talk more about the UC data rather than the Crohn's data, and we'll be focusing on the appropriate use, the precautions and everything else about the Tofa. So we know we have appropriate number of the drugs actually now available for the UC. It started with the aminosalicylates, then we have corticosteroids and immunosuppressants, some role of antimicrobials, then TNF alpha inhibitors came. Infliximab, Adeli and biosimilars were available with us, followed by Vido, which is also available as of now in India as well. At least the infusion is available. The subcutaneous we are waiting. JAK inhibitors, as Abhishek has told, they are actually relatively newer kids in the block, approved in 2018 by US FDA for use in UC. Tofa is available, Barry is available, but not for UC. For other indication, it's available. The other ones, the other JAK inhibitors are in pipeline. At least they are not approved by US FDA. Surgery is very rarely used as a reserve class of treatment. The problem with the current treatments are one, they are not effective fully. As Dr. Bhatia told, around 1/3 of the patient, they still they don't respond, or they partially respond. So we need something to counteract in failures. Then different drugs have different issues, like biologics have different issues. The side effects problem, though Vido has a relatively good safety profile, but TNF alpha inhibitors, they have their own issues with the safety. Substantial morbidity also, change in the quality of life also happens. The cost issues are there. The problems of the infusions are there. They are, most of the time they need to be given by infusion, except the adalimumab, and then the complication they happen. So we required something. JAK signaling pathway, as Dr. Abhishek told, is one of the pathway which is actually blocking almost all the cytokine effects. Actually, it is a common final pathway, and different JAK inhibitors are there available, which are there, and we're acting on different JAK pathway. Now, Tofa was actually tried as a JAK3 inhibitor, but actually it still has the effect on JAK1 and JAK2 as well. So we would label it as a pan-JAK inhibitor rather than the selective JAK inhibitors. Since JAK pathways, they are involved in other biochemical reactions as well. So we expect some side effects by JAK inhibition. Some kind of hormones and other things, they also involve the JAK pathways. So some side effects, they are expected, and we'll discuss about them. So we will not go in detail of the pathogenesis, they already been discussed. Now, how do JAK inhibitors differ from biologics, and why do we need them? The good thing about JAK inhibitors is that they work intracellularly. This is one. Second, they are synthetic drugs and not proteins. So immunogenicity issues not there. And the loss of response, as would happen, especially with the TNF alpha by antibody formation, would not happen with the JAK inhibitor, especially the Tofa. They're very small molecule. They are possible to be administered orally. After 5-ASA steroid, the issue was of the oral administration for a drug which can be used in refractory cases. So Tofa actually is fulfilling that space. As I discussed, no immunogenicity, that's a great plus point, and that's why you don't need to combine them with the immunomodulator, especially the azathioprine, that which we require for the TNF alpha antagonist, especially the infliximab, because of the increased risk of antibody formation. They have a very stable and predictable pharmacokinetics, so a better safety profile as well. Now, Tofa is the one which is approved as a JNS kinase inhibitor. We discussed, Dr. Abhishek discussed about the details, so I will not go in the pathogenesis. We know it has been approved in May 2018 for moderate to severe UC patient, preferably who have failed on conventional therapy. Though it can be used in naive patients, but preferably who failed on the conventional therapy. AG recommends in that. 2019 guidelines of AG also state that. Now, the data of efficacy of Tofa comes from the initial trials, which were the Octave studies, actually. The Octave 1 study and Octave 2 study. They were actually the replica of each other, these two studies. And if I just elaborate, both the type of patients, whether there were the TNF naive or TNF exposed, they were there in this trial. At this time, when the study was published and conducted, the Vido was not available, actually. Vido was not available. So you will not find the patients who were Vido or Vido failure in this group. So Octave 1 and Octave 2, they were the studies. And if we see the initial remission, if you see, that is defined by the total Mayo score of less than 2 with no subscore of more than 1 and a rectal bleeding subscore of 0 at 8 weeks. This, if I focus here, this is significantly different than the placebo. Now, as Dr. Abhishek told, the Tofa induction dose is 10 milligram twice a day rather than 5 milligram twice a day. So with a dose of 10 milligram Tofa, the difference of response was significant between the placebo and the Tofa arm in both the studies. And mind it, again, revising, it included both kinds of patient, TNF alpha exposed and TNF alpha antagonist naive as well. Now, mucosal healing, because they see the clinical response can happen, but mucosal response, if we see in both the studies, Octave 1 and Octave 2, they also were significantly better in Tofa arm as compared to the placebo. And once we see the difference from the placebo in the form of percentage point, is also very significant, you know, at least 15-point difference from the placebo in both the studies. And once we go to the another study called Octave Sustain, where actually it looked at the maintenance at week 52, the same would happen. Both the groups, 5 milligram group and 10 milligram group of Tofa, the remission was clinically significantly different from the placebo, little better in the 10 milligram group as compared to the 5 milligram group. Now, another point which is very, very important once you start a medicine, or especially in the UC, when you require a medicine for the acute severe cases, is the onset of response. Now, some issue that happened with the Vido was the same. I mean, Vido has a little delayed action, so that's why it is not a good drug for to be used in acute severe UC. And Infliximab is the biologic we still prefer. Now, Tofa, if we see this graph, if in Octave 1 and Octave 2, you see at as early as 2 weeks, you see the gap from the placebo. So there's a significant difference of the response in the form of Mayo score, which would happen as early as 2 weeks. And once we go deep into it, I mean, if you just dig deep into the stuff and you go for the clinical scoring, that is usually defined by the rectal bleeding and the clinical response, the good response would happen at as early as day 3. You see this graph separates from placebo, where at day 3, there is a clinically significant improvement in rectal bleeding scores as well. So there's this is a ground for a good drug which can be given orally and which can be given in moderate to severe UC as well, especially even in the failure group where TNF-alpha exposure has been there. So, and we have a drug which is a relatively faster onset of action as early as day 3. Now, think of the people who actually did not respond at 8 weeks. Suppose you started a medication, 10 milligram twice a day Tofa, you actually went ahead till 8 weeks, and then 50% of the patient who did not respond, and then they were put in the open label study where the dose was actually extended 16 weeks. And that means 8 weeks plus another 8 weeks. Actually, there was recruitment. And you see at 16 weeks, 3 out of the 4 patients would respond. Well, that's quite significant. I mean, 75% response at week 16 is a good response in case of an oral drug. And as we discussed, if you see the remission and the mucosal healing, and you compare the prior TNF exposure, whether they were TNF naive or TNF exposed, though there is some difference in the total remission if you compare the two groups, whether they were TNF exposed or TNF naive, but then the difference was significant as compared to the placebo. So this just means the moral of the story is you would have a good response in both the group of the people, whether they were priorly exposed to TNF-alpha antagonists or no. Now, maintenance also, as we discussed, there's significant effect in the form of 52 weeks, if you see the remission at 52 weeks. And if you classify this total Mayo score of less than or equal to 2, this is significant in both the groups, 5 milligram and the 10 milligram group. Safety is a great concern sometimes, so we should discuss about the safety as well. And once we see this safety in the form of adverse events, the infections, nasopharyngitis, other adverse events, and when we compare the two doses, maybe 5 milligram and the 10 milligram, here as compared to the placebo, nasopharyngitis is the one which probably is a little concern in both the groups, more in the 10 milligram dose. The infections are not much, but once you dissect out and you see the herpes zoster, that is significantly higher in 10 milligram dose once you maintain the person on the 10 milligram rather than the 5 milligram. So two things which I want to highlight as compared to placebo is nasopharyngitis and the herpes zoster. And once we further dig into the herpes zoster and other infection and you look for the opportunistic infection, it's the only herpes zoster that actually persisted. And once you go deep in this study, the serious herpes zoster was not significantly higher. The multidermatomal herpes, and this was not very common in these, and they were all manageable herpes zoster which happened. More so, there have been guidelines which recommend that adults with IBD over the age of 50, they actually should be vaccinated for herpes zoster. And especially now the non-live subunit vaccines are available. So there is recommendations of recombinant zoster vaccine for the person who actually are going for the TOFA. Now, other side effects, including the, this non-melanoma skin cancer and the GI perforation, the adverse cardiovascular events, they were there, but they were not very significant in the TOFA group. There were some, issues of dyslipidemias that happened, but they could not get converted into adverse cardiovascular events. So monitoring is required in view of these. The person who is on TOFA should be monitored. At the baseline, there should be a CBC, as Dr. Abhishek told, the routine CBC, liver function test, kidney function test, the lipids, they should be checked along with the hepatitis B. Of course, you should check about it, and tuberculosis. Monitoring has to be there. At 4 to 8 weeks, you need to repeat the complete blood count, look for the dyslipidemia again, and LFT you have to monitor, and you have to increase the monitoring. If 1 or 2 values are high, then accordingly we have to take the action. So if I just summarize the problem, the discussion till now, and we come to the actual practical use, we saw that in Octave 1 and 2, the induction dose was 10 milligram twice a day for 8 weeks. The persons who did not respond, they responded at 16 weeks. So if you are actually putting a person on this dose for 8 weeks and there is no response, consider shifting to 8 more weeks. And of course, at age 16 weeks, person doesn't respond, this is a ground for stopping the medicine. Now, once you go to maintenance, for person who are TNF naive and they responded, consider with maintaining with the 5 milligram. And if they were TNF poor responders, consider maintaining with the 10 milligram. We saw that 10 milligram maintenance may lead to some increased incidence of side effects, including herpes zoster. So preferred dose for maintenance is 5 milligram twice a day. There is some adjustment for the liver and renal issues. They have to be taken care of, and some drug interactions are there. We saw that it's a good drug with rapid onset of action. The clinical effect can come as early as 3 days, especially the rectal bleeding scores can get better within 3 days. And safety is okay. I mean, there is increased incidence of herpes zoster, we should take care. One problem of thromboembolism, Dr. Abhishek discussed, actually has been more shown in the RA trials rather than the UC trials. The increased risk of this pulmonary thromboembolism and other thrombotic risks were not significantly seen in the UC trial as compared to the RA trials, though there is some black box warning by the FDA. One has to be careful about it, but then the risk is not apparently high in GI trials. Lipid profile we should check at intervals, and we should look for the CBC and LFT as required. Now, real world data is also almost same as the initial studies. The remission at 8 weeks and 16 weeks has been significantly better than placebo, as was in the trials. So just to conclude, ladies and gentlemen, JAK inhibitors are a new class of oral small molecules for IBD. They have their rapid onset of action, especially the TOFA. It starts early. They are very stable pharmacokinetics with very low or no immunogenicity. So they don't require any combination with the immunomodulators. They are effective in both TNF naive and TNF exposed people. That's a good thing to take care of. And they have a manageable safety profile. So one need to take care of the side effects, but then they are still manageable. And of course, we need to appropriately position them at appropriate place in the management to have a maximum good effect. Thanks a lot for the patient listening.
Excellent presentation, Dr. Pawar.
Thank you, sir.
I'll just take the discussion forward from the last point of your presentation. How do you position itself in the therapeutic algorithm of IBD at present in India?
Yeah, that's a great question, sir, because we have now video also available with us. So yeah. It's the positioning as per the AGA, and what I think is if there is a person who is having a poor profile for biologics, it's not a first line, let me tell you. It's not a first line. So who has a poor biological profile for the probiologics, poor pharmacokinetic issues, age which is not favorable for the biologics, and this is a usual candidate, and who should have a moderate to severe UC. This is a one-liner what I would say for the TOFA. In acute severe UC, because it acts faster. It acts faster than Vido. The Vido takes around 2 weeks. I mean, the Versity trial, if you look, Vido actually has a little delayed action as compared to the TNF alpha. So infliximab has been the drug of choice forever, other than the cyclo. But then this is also one candidate we have right now, which has an oral, preparation to be used. So this we can position there as well. So moderate to severe UC as a first or second liner, mainly the second liner, with a poor profile for the biologics, especially the whatever available, and in severe acute UC as we position it. This is probably, and the patient preference also. I mean, if patient is preferring oral treatment, then this is a wonderful drug available now.
I think I'll go slightly away from your concept, or because you see, this is a drug which is available in oral form. Number one. Number two, the cost factor is not a big thing in this. Number three, if you see the data which you have already presented, the response rates are as good as the biologicals. So why shouldn't we give it ahead of the biologicals in moderate to severe IBD, so that the patient gets the same effect with a lower cost and an earlier effect?
Yeah,
this is how I want to position it at present in the therapeutic algorithm.
Yes, sir.
Any comment on that?
Yeah. Theoretically, you are right. I mean, if you see Asian countries where biologics availability is an issue, even the awareness is an issue, and we know that
around is a very big factor. Cost
2% of our people who deserve biologics, they only get biologics. Otherwise, 98% don't get it. And we know we don't treat the IBD at an appropriate stage with appropriate drugs. That we know of. Yes, theoretically it's fine, but then if you go to the data which has been there supporting the use of Tofa till now, actually positions is like that. Yes, theoretically you're very right. I mean, especially because of the low cost oral preparation, this can be positioned a little better. As I mean, even in before the biologics. And Vido especially is very costly. I mean, if you see the single
Vido is costly,
dose, very costly.
Adalimumab or Inflex, they are costly drugs. People don't afford it for a very long time. The compliance is not good after, let us say, 3, 4, 5 months.
Yeah, theoretically you're right, sir. The only problem is the data is available like this.
Data is not available. And actually we don't have any head-to-head
There's no
comparison between the biologicals and Tofa, to say that it is better or equally good in that. Yeah. Are there any questions from the audience?
Yes, sir. We have the 2 questions, sir. One is from the Dr. Juvin Sharma from Haryana, Gurgaon. For the Dr. Abhishek, do you see a role of testing patients for the TNF?
You're not audible, Mr. Gupta. Your voice is breaking.
Oh. Am I audible, sir, now?
Yeah, you're better now.
Do you see a role of testing patients for the TNF levels and cytokine level quantification to choose the ideal biologic as a personalized treatment, anti-TNF versus anti-JAK status?
See, as far as the cytokine status is concerned, we still don't have the measurement of cytokine level available in India. We do have measurement of IL levels available, but not the cytokine levels per se in general. And no, I won't suggest the measurement of anti-TNF because it has been shown in trials that it's not an effective strategy.
I'll just give a rejoinder to this, because you see the pathogenesis of ulcerative colitis is not dependent on one antigen. It is a very complex pathogenesis, and there are so many targets, so many mechanisms which do this pathogenesis. So measuring one cytokine and giving drug accordingly, at present we have not reached that level. Maybe in future we can reach that level, but not at present, that we measure the cytokines and then decide which personalized therapy has to be given.
Can I have a question with Dr. Pawan Rawal?
Yes, sir.
Yeah.
Dr. Pawan, I just want to know for how long you can give the Tofacitinib. How long you can give?
The long-term data, I mean, if you talk of the till now, I mean, which is available is around 4 to 5 years. The safety profile we discussed already. The further data, it's still coming. Extension study would be coming and we'll be receiving them. The results which have been still published, they were published at 52 weeks as we published the remission. But yes, those studies have continued, and the at least we have now 4 or 5 years stuff which is available as of now from the start. So, but then long-term safety issues, as would happen with the AZA group and others, they still need to be known about. I mean, is there any concern after 4 years or 5 years that people are not aware of?
And second question is, I'm not an IBD guy. This question is from Khaturia, Dr. Khaturia, or to you, because what I understand with a very little knowledge about the IBD, the TNF, anti-TNF drugs, they are going through the TNF pathway. And the Tofacitinib, they are not going through the TNF, they are going through the interleukin, JAK-STAT pathway. I think both are different.
Yeah.
So do you think combining these two drugs, I know it is going to produce a severe immunosuppression, or as Jubin has asked the very right question, can we find out is the TNF group is predominant in this patient, or interleukin JAK-STAT pathway is predominant, and we can decide about the therapy? Actually, because this was the thought, it came in my mind, because when we look at the pathogenesis of the ulcerative colitis and the drugs, how it is acting. One is acting through the TNF alpha and one is acting through the interleukins, JAK-STAT pathway. So what is your take home on this? What will be the right approach, or what I'm thinking is right or wrong?
So the trials have shown that this is not an effective strategy to measure the anti-TNF levels. And see, as we all know, it's a multifactorial disease and the pathogenesis is still unclear. So there are so many pathways involved. Combining the two drugs, no data is available. So my take-home message is we cannot devise this strategy right away, right now.
I think it is a research topic.
Yeah, I agree. I mean, theoretically, it seems very, lucrative, but then, adversity, the consequences, whether it multiplies into the benefits or not, it needs to be seen. And with the class of drug you are dealing, the side effect profile is very, very huge. People who have combined TNF and AZA was an issue because AZA would increase the efficacy of TNF alpha antagonist. There's a different reason for that. So, I mean, this is a question needs to be answered. Rather, right now, you can't have a policy like this.
Is a harm in giving as a first line therapy?
There is no harm, Dr. Rajesh. It's all about the lack of the appropriate data, because whatever the studies,
I agree.
So as Dr. Vivek Bhatia told, it seems very lucrative because it's an oral drug, relatively safe, side effect profile is still manageable, cost issues are not there, efficacy is good, onset of action is good. Let me tell you a very important thing. There is rapid clearance as well. This drug would be cleared very, very fast. So suppose you are dealing with a patient of severe acute colitis, and probably if you think the person would fail with this treatment, you will require a colectomy. This is the first drug that will be cleared out of the body. So the later side effect would be least with this. So this kind of profile actually makes you, lucrative stuff to be used as a class initially without any exposure. Also, you can start it as a first line.
Similarly, as we said that it is useful in the moderately severe UC, but I'm just asking because the data is not available when we talk about the mild or when we talk about the severe UC or the duration. It is all what we are waiting for the data to come up, and then we will be able to convey the message in a appropriate manner that can we use in which group of the patient, how long, what doses. Is that right?
Yes, of course. I mean, before you at least do think, I mean, you have to see whether you are hitting stuff with a hammer and don't require to hit with a hammer. Suppose you are going in a step-up treatment, not a top to down, but then you are going a step-up treatment. You can't have a Tofa as a first liner. For mild, for the mild UC.
Are you comfortable with all these studies who have combined moderate IBD with a severe IBD? Because as you say that in severe IBD, you have to have drugs which act very fast. You can't have a severe IBD waiting for 2 weeks or 3 weeks or 4 weeks. and then say, no, it is not good, we'll go shift to another one. I think for severe IBD, the drug effect has to be very, very fast. So combining these two groups of patients to see whether their efficacy is there or not, I think that the studies should be like that, that moderate IBD separate group and severe IBD separate group.
Yes, sir. I mean, but on the guidelines and AGs, they don't actually separate them significantly.
Yeah, they
Severe
should.
acute colitis is totally different. Once we are dealing with this, and I think there is some trial going on PGI. Vishal is doing a trial. He probably is involving the combination of the drugs as well in this class. I'm not fully aware of, but then he's doing some study based on this. So I think, but this is a demand of time. We should think about it.
Any other question from the audience?
Sir, one more question from Dr. B.S. Rawat from the Dehradun. Is Tofacitinib advisable in the colon cancer?
There's no data. I mean, yeah.
No data is available, sir.
What's the logic of that?
It's a JAK-STAT pathway. Yeah, it's acting on JAK-STAT pathway. Yeah.
And as most of the IBD drugs are used interchangingly in the Crohn's and the ulcerative colitis, why this drug is not have a good effect in the patient of Crohn's disease? We talk about the salicylates, we talk about the steroids, we talk about AZA, we talk about the TNF. Most of the drugs are commonly used in both the disease. But Tofacitinib, why it is not shown good result in the Crohn's disease? It is the TH1 and TH2 pathway is responsible, or there is any other explanation?
No, there is data available. We deliberately did not present because it is not going to convert into a clinical application.
I'm saying why.
It's very difficult, but then we need more data. Actually, it's all about the evidence available. We don't have a strong evidence for this drug to be approved for Crohn's as of now. Future we don't know of, but then till now, yes. Theoretically, it's very difficult for me to comment why the question difficult to be answered. Why this JAK kinase pathway is not, is used for Crohn's, or why it's not so effective. This still to be, I don't know. I mean, it's very difficult.
One more question, sir. For acute severe ulcerative colitis, would you prefer an oral drug or IV drug?
IV.
Okay. Yes, sir. These are some questions that audience have asked.
Can we wrap up the session?
So can we wrap up the session, sir?
I think it's a dinner time on a Saturday.
From each speaker, sir.
Yeah, it's a dinner time, especially on Saturday.
I think we should thank both the speakers. They have done an excellent job in updating us on this Tofa molecule.
And sir, at the MSN, we are also very, very thankful for your valuable time. And we are very sure this session will be useful for number of the gastroenterologists, physicians for a better patient care in the ulcerative colitis, sir. So from the bottom of the heart, MSN is very, very thankful for each one of you, sir. Thank you very much, sir.
Thank you very much.
Thank you. Thank you, Dr. Bhatia.
Thank you.
Okay.
Bye-bye.
Thank you. Bye. Good night.